Good afternoon, everyone. This is Holly Lemaster, the Program Coordinator for the Colorado MESA Initiative, and welcome to our First Friday webinar. I'm going to start with just a few housekeeping items, reminding you that you can hide your GoToWebinar control panel, pardon me, if it's getting in the way of you seeing our presentation this afternoon. If you're having any trouble hearing me, you won't be hearing me say this, but hopefully you're reading the screen. You can use your telephone to call in to access the webinar with the instructions on the screen. And I'd like to just test and make sure you can hear us. You'll notice you have a little hand icon in your control panel. So if you would raise your hand and let us know that you can hear us, that would be fantastic. I'm just going to check my attendance. Great, we got a bunch of hands raised. That's wonderful. So we'll move forward. Just want to also let you know that in your control panel is a place to type questions. And you can type your questions in at any time during the presentation, and we will address them when we get to the end. Okay, handouts are available for today's workshop, and you can find those on our website, coloradomesa.org. You will need to sign in to access the events section. Look for upcoming webinars, and you'll find the handouts there. By Monday, we will have posted the archive of this webinar, and you'll then find it under the Classroom section and Webinar Archives. So you can watch it again or share it with your colleagues at your convenience. So the Colorado MESA Initiative, for those of you who are not aware, our project stands for Medicare Experts Senior Access, and our goal is to help you be more adept at your Medicare coding and documentation so you can be paid more fairly for the good work that you do taking care of Colorado's seniors. This project is a collaboration between Senior Care of Colorado, the Alzheimer's Association Colorado chapter, and we are fully funded by grants from the Colorado Health Foundation, the Kaiser Permanente Foundation, and Caring for Colorado. Our guest speaker today is Dr. Gregory Gahm. He is currently medical director for 11 long-term care facilities in the Denver metro area, and an associate clinical professor of medicine in the geriatric department at the University of Colorado School of Medicine. He has been president of the Colorado Medical Directors Association. Is that current or is that past? That is current. He is currently the president. And a native of Colorado, he graduated from University of Colorado and also has an MPH in medical informatics and administrative medicine from Harvard. So Dr. Gahm, welcome very much. Thank you for being here today. Oh, and I'll also just mention that he is serving as an adjunct faculty member to our MESA core team and is working on the update of our clinical pearls and protocols. So we're looking forward to that coming out in the near future. And today we are going to talk about, and I'm interested to hear about why diagnosing and treating UTIs is your pet peeve. Okay. So I know we'll enjoy getting into that. So Dr. Gahm, take it away.
Thanks. And I know, actually, I thought I knew most of you, and then I see the names and realize I don't know most of you. But I've had a chance to meet a lot of you, and I'm sure this will be our last interaction. Sorry that you had to look at that really nice picture in the waiting room there for the past few minutes. I guarantee you he does not have a UTI. And as we go through this, I'm not sure what all you have for handouts, but your other option for handouts, you're welcome at any time to email me, both for the handouts and references, if you'd like those. My email is simple. It's my last name, GAHMMD@AOL.com. And Don knows that, or they have that if you need that later. All right, so right into this, we'll jump right into it. The objectives here for the day. First and foremost, we want to discuss the difference between asymptomatic bacteriuria and UTIs. Then we're going to review the criteria for diagnosing a UTI, discuss treatment options for both, and then we'll talk about some odds and ends about UTIs, like how to prevent recurrent UTIs and so forth. Normally when I'm giving this live, and I do this as an in-service for lots of my facilities and a lot of long-term care, we start with making everybody sit back and forget about UTIs for a moment and just answer the question, what are the signs and symptoms of any infection? And you can do that briefly in your mind here for just a minute and sit back and just figure out whether it's you or a family member, a friend, or a patient what do you look for that tells you that they have an infection and not just some inflammation, dehydration, hypochondriasis, who knows? But what makes it an infection? And actually, if you go to, and a lot of my information is extrapolated from evidence that we get from CDC where they work on this stuff. But if you go through it, we'll go through this pretty quickly. These are the things that we usually find listed as signs and symptoms of any infection. And they're all pretty straightforward, pretty simple: fever, chills, rigors, cough, pain or tenderness in a particular spot. And I don't need to read this slide to you, just because these are pretty simple, straightforward things. Microbes found in places where they don't belong is one we tend to focus on a lot, but it's really just part of the big picture. So then the next question that we get into, which is really going to be, as we move through what we're going to talk about today, the crux of what I hope you take away today, is just the question, what is asymptomatic bacteriuria? And it's defined here on the slide. It's just isolation of more than 100,000 bacteria from an appropriately collected specimen, urine specimen from somebody without signs or symptoms of a UTI. So this is the basic person that you go in and you draw urine because they were acting crazy last night, or for whatever reason you just draw urine and they grow bacteria. Next, and actually before I leave that, I want to share something. Many of you may know John Morley. That name may be familiar. If it's not, John Morley is the editor of JAMDA, Journal of the American Medical Directors Association. He's a friend of Mike's, has worked with Don. We see him every year at AMDA. He is, I think he trained in England. He is just a gregarious, entertaining speaker. He's wonderful. He's also head of geriatrics, I believe, at University of Chicago. And he does these wonderful things because he has all these fellows that work for him. And so he just sends them out on assignments. I want you to go do this and do that. So you'll see him if you ever read JAMDA. He writes an editorial almost every month. And he'll take a topic and he'll just summarize an entire topic down into 2.5 pages and tell it like it is. Last year in San Antonio, he was talking about asymptomatic bacteriuria, and one of the things he said was, oh yeah, about 3 years ago, he took 2 of his fellows, and he said, I want you to go figure out how prevalent this is in nursing homes. Go do 700 consecutive long-term care patients, not subacute, so none of those folks, just long-term care. Go to as many nursing homes as you need to, go collect samples, bring them back, and let's culture. And what he found out on what symptoms, no symptoms, treated, not treated, it doesn't matter. Any given day, walking through, doing 700 patients, he found out that 64% of nursing home patients would grow more than 100,000 bacteria in that culture any given day. Wow. And it was pretty consistent across 200, at the 500, and finally at the 700 patient level. The numbers were all pretty similar, so he quit at 700. I don't know that he's ever published it. He talks a lot more than he publishes, and most of what he publishes is in JAMDA. But anyway, put that in the back of your mind that on any given day, 2/3 of our patients will grow bacteria. We'll talk a little bit later, I think, about why that happens. Okay, so signs and symptoms of a UTI, and I'll give you the disclosure up in front here. What I'm about to share with you, it comes from the best data currently available. Unfortunately, I understand, I have some contacts at the CDC, and I understand this month they're going to release their new criteria of what they think constitutes a UTI. The last time they did this was in about 1990 with the MCGEER criteria, and that was the ones they accepted, and we'll talk about that here next. So I apologize if what I tell you today has some minor modifications by this time next month, but they were unwilling to share ahead of time what those changes might be. I don't think they'll be significant, but if they are, I'll let you know. So the first thing about urinary tract infections, bacteria in the urine is not the same thing as an infection. So for an infection, you really need invasion by and multiplication of pathogenic organisms in a body tissue that leads to a pathologic state. The diagnosis of a UTI really requires both those things, the organism and the infectious process. In non-catheterized patients, I would also tell you that if you get mixed flora, more than one bacterial species in the urine, the first thing you should do is apologize that you're not blaming anybody, but you're going to throw it away and start over. In a true UTI, that really just doesn't happen. Bacteria all have their own individual characteristics. Some grow faster than others, and they always take over. If you get multiple flora, mixed flora, it's a contaminated specimen. And that's why you have to apologize up front, because undoubtedly you'll offend somebody, whoever did the straight cath or whoever was in charge of doing it will think you're blaming them. It has nothing to do with blaming them. It's just a fact of life. Of course, with Foley catheters, that's not the case. They have all kinds of reasons to get that. All right, so here's the criteria. These are adapted from the MCGEER criteria, and this is actually the only handout that's worthwhile that you'll get from me today. It has all of these in a little box below it on a single page. And it's the only one that, you know, when I do in-services, I leave it with the staff. We put it out at the nurses' station. In my facilities, we try to require the nurses to use this before they call you. So as you look at this, the very first thing, they have to have fever, chills, or rigors. At the end of the day, if you count these real quickly, you'll see there are 6 boxes. In this, if there's only one thing that you take away from today's talk, this is it. To diagnose a UTI, you need to have check marks in 3 of these boxes. 2 doesn't count, even if you have best of intentions. It has to be 3 boxes, and it has to be honest answers. So the first one, fever, greater than 100.4. You know, that's a little bit goofy in seniors because sometimes they don't generate a real big fever, so fudge that a little bit. You know, make it 100, make it 99.8. Probably don't want to drop it much below that, but, you know, fudge it a little bit if you have to, and it's new for that patient. Chills or rigors. The second criteria, new, increased urinary frequency, burning, or urgency. The third one, new, and again, new is a key word here, flank or suprapubic pain or tenderness. The fourth one, blood in the urine is a new finding. So if you got somebody that's been on Coumadin and recurrently has blood in their urine, it wouldn't be a new finding of hematuria. And then, of course, the one that everybody gets is sort of the free pass wild card. Worsening mental or functional status, fine, check it off. They have behavior, so go ahead and count that. And then the last one is the lab finding, either significant pyuria or a culture that grows more than 100,000 colonies. But one of the things I would tell you up front on the handout that you'll see is those first 5 criteria. What I tell when I do the in-service, I tell them you have to have 2 of those checked off and documented in a place where somebody can find it in the chart before they call you and ask for a UA. Because even if all they have is behavioral abnormality, you get the UA and you grow 100,000 bacteria, well, at the end of the day, if that's all you've got, you've only got 2 criteria, and the best you can come away with is asymptomatic bacteriuria. Even if you have, I mean, the problem is as soon as you see those bacteria and you've got the behaviors, your desire is to make it a UTI. It doesn't matter if they have one or not. Everybody wants you to make it a UTI. And the reality is, without one of the other 4 criteria that you can honestly and objectively say is there, you don't meet the criteria for a UTI. Other things in my in-service, I don't have to tell you guys this, but the little line at the bottom of this slide, urine odor, color, and appearance of the sediment in the urine are not anywhere in this list. They're not part of the criteria. That's not important to you guys, but certainly with nurses, that's what shows up in their nursing notes. That's often why they call you. This urine smells awful. I usually ask them, when was the last time they smelled urine that smelled really good? You know, and the color really doesn't, other than gross hematuria, color doesn't really play into it, and sediment is not a part of it as well. And then I'm going to go real quickly just through a couple of studies that I think will help reinforce some of the fears people have about accepting this as true. This is actually taken, this is why John Morley went out and did his study. He looked at this study that found out that half of women and anywhere from 15 to 40% of men in nursing homes have asymptomatic bacteriuria at any given time. So what he did was really just go out and say, yeah, that's true. I mean, he came up with 64%, which if you add these up is really, this is saying 65 to 90, so his numbers were actually a little lower than this. The second part of this particular reference was to look at, does antibiotic treatment help for these folks with asymptomatic bacteriuria? And it was this wonderful study, 191 residents that had incontinence and recurrent bacteriuria. And all they did was randomize them. When we do the UA, we're either going to immediately treat you, it was blinded randomization, or we're going to delay treatment until you have symptoms that meet the criteria. And in the group that got immediately treated, they not only didn't do any better, they tended to have more frequent incontinence and real UTIs, and they had the emergence of antibiotic resistance. The conclusion on this study was there's just no justification for treating asymptomatic bacteriuria, and it does lead to problems. Here's another study that's really nice, because then the question is, well, what happens if we don't treat it? Aren't we going to end up with more people getting septic, uroseptic, end up in the hospital? And, you know, aren't we better off treating a few people that don't have an infection than missing everybody? So this was a really nice study, and normally I do this, I flip through and you don't get the answers right off the bat, but here you can jump right to the conclusion if you want. 50 institutionalized elderly women, asymptomatic bacteriuria, and for a whole year they randomly either received antibiotics for their episodes or they got no therapy unless they developed symptoms and met the criteria. Only 5 of the 50 went more than 6 months with no bacteriuria. For those that got no therapy, they kept growing the same organism over and over and over. Didn't really matter. They never got sick, never met criteria. Those that got the antimicrobial therapy, twice as many of them got reinfections, 10 times had, I'm not sure, I'd have to go back and reread it to find out 10 times if the other group got 0, except I think the reason the other group had some adverse antimicrobial drug effects was because some of them actually went on and had UTIs and got treated. And then the other part was, of course, not unexpected. The group that got antibiotics for their asymptomatic bacteriuria got increasingly more and more resistant organisms. At the end of the day, there was no difference in cause-related morbidity or mortality between the two groups. So the groups that were not treated with antibiotics unless they met criteria didn't do any worse. They didn't end up in the hospital septic. And again, the conclusion to this study was simply that the data support what were the standard recommendations at the time, that we have no treatment for asymptomatic bacteriuria in this population. Catheterized patients, it gets a little bit harder. What I would tell you is important here is course number 2 and 3 are the same thing, and this is really for nurses. The appearance and the odor of the urine don't have anything to do with infection. In all of us, if those of you on the talk or those of us sitting here, if you put a catheter in us, within 48 hours, we're going to grow more than 100,000 colonies. It's just going to happen. So we're always going to have that. So if that's always there, what do you do for criteria? Well, it's really about the same criteria. You know, you're looking for fever, you're looking for chills. You depend a little bit more on the lab. Look for an increasing white count to go along with infection. It's just a harder diagnosis to make because you're always going to find bacteria. So there again, you fall back to, are they infected? They always have bacteria. Start with that as a starting point, and then you have to step back and decide whether or not they really look like they have an infection. Okay, so other considerations. Let's just run through these. In long-term care, non-instrumented men, think about BPH. You know, it's really hard it's really an anatomy thing, that it's mainly women that get UTIs because those bacteria just don't have to go very far to get into the bladder and get access. And one of the other things, I take a little bit of time off here to step aside and say, why do they have so much asymptomatic bacteriuria? One of the few things that really is a physiologic change of aging is that we lose, our thirst receptors lose sensitivity. You have three major thirst receptors, carotid, atria, and renal, and they just lose their sensitivity, which is why older folks don't drink enough. They don't sense that they're thirsty. And in fact, we see it all the time. I used to live in Arizona, and we see thousands of people every year come in with significant dehydration, and none of them thought they were thirsty, or very few. And you look at them, and they're way, way down. So they lose that sensitivity. They don't drink enough. Well, what happens? If you don't drink enough, it takes, I mean, all of us, you know, we drink water. I mean, I would wonder how many of you sitting there right now have a glass or a bottle of water within arm's reach that you're sipping on throughout the day. And we all go pee 2 or 3 times a day. But left on their own, older folks once a day might be might be a stretch, unless they're on diuretics or something else. But what that means is it takes forever to fill up their bladder. And if it takes forever and they've got just a few bacteria in there to start the day, and they double every 20 minutes, it doesn't take very long for those bacteria to just keep doubling and doubling and get over 100,000. If you can keep them drinking, then you can flush out those bacteria, and they keep having to start at ground zero. All right, so that's a basic thing. So for men, let's talk about the BPH for just a minute. One of the problems with a big prostate is it's an obstructive lesion. Again, nothing you don't know. But what happens with that obstructive lesion there with that big prostate, because the urethra has to go right through, dead center through the middle of it, in order for the detruser to create enough energy to overcome that obstruction, the bladder has to be pretty full, 3/4 to full, before you can overcome that. And then even when it overcomes it, it's not like suddenly you've overcome it and now it's like having a catheter in there and the urine all just drains out. Now, typically in men, if you do post-void residuals with their big prostate, the best they can do usually is get 2/3 of it out, and they're left with a bladder that's about 1/3 full of urine at the end. Now, the problem is, with BPH, we also see some incontinence, because a lot of times their bladder gets pretty full and they have overflow incontinence, or they have a little dementia, they don't get there in time, and we see incontinence and we say, oh, okay, throw an incontinence drug at them, give them their Detrol, give them their oxybutynin or whatever magic pill we want to give them. The problem with that is that we're shutting down. That's really for urge incontinence. That's middle-aged women that have to go and they can't get there in time. And so because of that, they get that urge and they can't get to the bathroom in time. And that's because the detrusors are usually in spasm, and those meds work really well. But in these men, what we're doing is we're taking a problem where that bladder is really dependent on that detrusor muscle to get that urine out, and we're shutting it off. So now what happens? Now we got a patient that their bladder has to be not 100%, but it has to fill up beyond a normal capacity and stretch in order to overcome that obstruction at their prostate. And even then, it only drains 30%, 40%, and their bladder starts half, 2/3 full. And so they're constantly, it doesn't take them very long to fill that bladder up and get it out. So incontinence drug, bad thing with a big prostate. Treat the prostate. I don't know why urologists don't do more suprapubics, but that's a different discussion. Okay, next thing on here, and I won't take that long, I promise, on all these others. Double voiding. In older women that have had kids, one of the problems is as they age, everything top to bottom just gets a little bit floppy. All right? So one of those things that gets floppy is that uterus, and where it lands is right on top of the bladder. It's a really nice little pillow for that loose, floppy uterus. All right. So normally with your bladder, nice young middle-aged women, you have this nice erect bladder and the trigones right at the bottom, and everything drains down. All right, now we got this uterus sitting on top of it, so you create a little false pocket anteriorly where the uterus is hitting it, and so they pee and they finish and get up and walk away. Well, they've left that pocket of urine. It might only be 30 cc's, 50, 100 cc's, not a lot, but it's some. And if they had a few bacteria in there and they don't drink very much, it doesn't take long before you got a head start and you're growing bacteria like wild. All right, so here's a really simple trick for older women, especially little dementia, and if they don't drink real well. You got the CNA once a day, take them in to pee, and then have them just stand up, jiggle for a few seconds, just stand up for a few seconds, sit right back down, pee again. And what you do when they stand up, gravity works for you, and that urine drops right on top of the trigone. They pee again, and they get that last 30 to 50 cc's out. So you get to start from scratch. Now the problem is, it works really well in demented ladies. If they're not demented and you do that, they look at you like you're nuts, because they look at the CNA, you know, I don't do this, I tell the CNA to, and they say, really? For that 6 drops of urine, I had to do this? And then you just say, yeah. You don't try to answer it. Just say, yes, you did. We're going to do this once a day. And I can only give you, this is what I'll stray a little bit from the evidence, and I'll give you an anecdote. I started doing this, I read about it, didn't think much of it, but I started doing it at Julia Temple about 15 years ago, I guess. At the time, during our PIC meetings, we were seeing 18 to 20 UTIs per 1,000 patients per year. I mean, the statistic was 18. Which is really high. Right now, I'll tell you that in my nursing homes, as a target for the chain, we look at 4.5 or less. So we were, 4 times that. We started doing 2 things: increasing fluids and double voiding. And right now, 15 years later, we're still down at about 0.8 to 0.9 UTIs per 1,000 per year. So we got the problem almost overnight. Of course, being obsessive compulsive, we initially started by having them do it 3 times a day, and over the years I've gotten much more relaxed, and now we do it once a day, and it's worked really well. Okay, number 3 is really easy. Follow-up UAs, unless they're pregnant, which would be an indication to do a follow-up UA, don't do it, and I don't think we have many pregnant patients, so that shouldn't be a problem. Follow-up UAs, if we're looking at 64% asymptomatic bacteriuria, they're just going to lead you astray. Go look at the patient instead and try to figure out if they have an infection. If they don't look like they have an infection, don't meet criteria, there's just 0 reason to get that follow-up UA, and the CDC has been trying to say that for 20 years. We've already talked about the urine odor, sediment, color, so we'll skip that. When you get a UA and you see that line that says bacteria, when I do this talk, I hand out black Sharpies to the nurses, and I say, this Sharpie is to be kept with you, and its only purpose in life is to cross out the line that says bacteria on the UA. Cross it out. Don't ever look at it. Don't give it any credence. When you do a spun urine, when you look at it under the microscope in the lab, what they count as bacteria is anything. It's sediment, it's proteins, it's cell fragments, bacteria. It's about 50 different things, and they just all count as this sort of gross 1 plus 2 plus 3 plus bacteria. Cross it out. They're not bacteria, because this isn't from a gram stain. That isn't what they're looking at. Antibiotic choice, and here's a little interesting for you guys. Occasionally, especially if you've been over-treating with antibiotics for other reasons or for UTIs, or even if they have Foley cath, one of the problems is you'll get to a point where you'll see that antibiogram kind of thing, and 20 different antibiotics, and the only thing it's sensitive to is Zybox, IV gentamicin, something really caustic and expensive and awful, and everything else is either intermediate or resistant. Well, one of the things I would tell you is, for the most part, ignore it. When you do sensitivities even on urine, unfortunately, even in 2012, go to a lab sometime and ask them how they do it. And you'll see them do their little agar plate that they've plated, and they threw the antibiotic discs on it, and they wait their 2 days and things grow. And based on the zone of inhibition around the antibiotic disc, they interpret it as resistant, sensitive, or intermediate. But then ask him about the disc, and you find out that the antibiotic discs that they use only come in one strength. And that strength is based on the serum, normal serum concentration of that antibiotic. Now, I mean, that's great if you got a blood culture, or even if you've got pneumonia and you're looking at that. But for urine, it doesn't help at all, because most antibiotics, and I used to have a table and I can't find it anymore, but most antibiotics, penicillin and cephalosporins at the top, sulfa right below it, fluoroquinones right below that, and tetracyclines right below that, concentrate in the urine anywhere from 10 to 20 times what they are in the serum. And those, so when they do sensitivity, they don't check for that. It may be resistant to Bactrim, but if the question is, okay, but if the Bactrim concentration were 10 times higher, would it still be resistant? The answer is probably no, or likely no. And so typically antibiotics, I mean, again, we're looking for clinical cures, not lab cures. Give them an antibiotic. If they're not allergic to it, start with sulfa. Levaquin is everybody's favorite. Knock yourself out. We'll eventually get Levaquin resistance to everything, and then we'll have to go to something else. The next thing, cranberry, vitamin C, other home remedies. Again, feel free, but the reality is most of those things, the vitamin C works better if you're giving it as a juice, because they get the fluid with it. But even if you give it as the pills, you see, if you read enough literature, a minor improvement. Vitamin C, the same thing. If you acidify the urine, if you change it a little bit, most bacteria don't grow quite as well. There may be some minor benefit, but don't sell the farm trying to do it. And if they don't want to take pills, just get rid of them. The marginal value is almost negligible. Be careful with anticholinergic medications. Sort of like what we talked about with the prostate, there are a whole bunch of things that will just shut down the detrusor and keep it from working. And if it does, then you end up with a really full bladder with an ineffective detrusor. You don't get complete emptying of that bladder, and they'll get lots of bacteria. And by the way, if you got a full bladder and it's got more than 100,000, it'll start to invade per cc. It'll invade the mucosa, and they will get infections, and they'll meet the criteria over and over. So, more fluids to sort of flush the system, and anything you can do to completely void is always better. And any anticholinergic medications, if you're ever in wonder about what would be considered anticholinergic, under F329 on the CMS website, there's a wonderful chart. And again, if you're interested in it, I have it as a PDF. And actually, I think it's in our new, it should be, in our newest M.E.S.A guidelines, one new and improved. When we print that, there's a list of anticholinergic medications that CMS uses. And then, okay, so last thing I have to share, I've been doing this for about 2 years, talking in facilities about this, and one of the things I do it much quicker, but one of the things we do, if I've got 15 nurses sitting there, I have worked with medical records ahead of time, and one of the things we do is pull the last 15 charts of patients that were diagnosed and treated for a UTI. What we have them do is go through that chart, find out when the UA was ordered, and then look at the 72 hours leading up to that UA being sent, and find out if in the progress notes or nursing notes, did they meet criteria for a UTI, or did they just have asymptomatic bacteriuria? And just to jump to the bottom line, I've done it 12 facilities now. We've looked at 164 patients' charts. Of the 164, 7 people met criteria for a UTI. 3 people we couldn't tell, and 154 patients did not meet criteria. 164 people got antibiotics. The only offshoot to that I did at one facility where we had 17 patients, first one I did, 17 patients that had been treated for UTI, 2 met criteria, 15 did not. But the other thing I did was I went through and looked at all 17, and of the 17, 5 people in that period of time had also had C. diff. Of those 5, all 5 got their C. diff. One of them was one of the real UTI patients. 4 of them were not. 4 of them were patients that were treated for asymptomatic bacteriuria and ended up with C. diff. So it's not as simple as who cares, it's just an antibiotic. It does cause real harm. if we keep treating it. And final note is just hydrate people. And then this is the final slide. And now, I don't know how much time I actually took.
Well, we're just a little bit over, but it looks like folks are still engaged. So why don't you just take your time to wrap up? Do we want to see?
Are there any questions from the crowd?
Let's see. We can go back to that slide if you want to. Open up our panel here. I don't see any questions right now, so if you have any, please feel free to type them into your control panel question box. Would you like to go back to that?
Yeah.
Last slide?
It doesn't matter. That's fine.
Okay.
And also, if you come up with questions later, like what if the family insists? How do I deal with that? What if the nursing home calls and they demand it? Feel free to ask those questions. Send them to me online. Shoot me an email. I'll be a resource for any questions you have on this at any time.
Great. And with your permission, what we'll do when we archive this webinar is we'll put a link to your email address. So if you go to the archived webinars after Monday, we could also put up those 2 handouts that you referred to.
Yep.
So they would be with the archived webinar starting next week. Okay, last call for questions, folks. I'll just do a couple of wrap-up things while we're waiting to see if anyone would like to ask a question. Reminder to go to the website, coloradomesa.org, and access all of the resources there, in particular the webinar archives, training videos, etc. And it looks like I do have one question here. Most of the symptoms are not reportable with patients with significant dementia or underlying incontinence. How do you deal with this?
Oh, that's a great question. I probably should have dealt with that. In my dementia patients, I mean, yeah, they typically will scream or cry, or you don't know what it is. It's one of those funny behaviors. But I guarantee you, if you, on exam, they'll show you if they have a fever, so that'll be there. They're always incontinent. You don't know what to make of that, but you try to find out. Nursing staff, CNAs in particular, are pretty good at noting dysuria. And for those of you women out there that have had dysuria, when you have it, it is painful. It's a real thing. And so CNAs are a good resource. For the tenderness, I guarantee you, if you thump somebody with a closed fist in the CVA area right over their kidney, or if you take your hand and press down on their bladder, if it's tender, I mean, do it from the side where you can protect yourself from getting hit. They will jump. They will swing. They will scream. It does hurt. The hematuria is easy to pick up. So most of the time, even in the demented folks, a little bit more work, but you can figure it out.
Great. Thank you. Any more questions you folks would like to ask from the audience? So I'd like to remind you to join us next month. Our topic has yet to be determined, but we're leaning toward discussing our Progress Note Review program. So if you have any interest in submitting any of your progress notes to have them reviewed by a professional coder, it's an absolutely confidential process, and the cost is covered by our grant funding, so it's a wonderful resource that you can take advantage of. I am rather sure we'll be talking about that on the 5th of October, which will be our next webinar. And as Dr. Gahm mentioned, he's happy to answer any additional questions that might come up, so we will put a link to his email address with the archived webinar. Dr. Gahm, thank you so much for that wealth of information. As a non-clinician, I feel like I'm very well educated about UTIs now, so thank you for your time, and thanks to everyone who participated today. See you next month.